Recording in
Okay.
progress.
Got it. Good evening, everyone, and welcome to the 26th episode of e-Gurukul series of surgical skill transfer and solving clinical dilemmas by distinguished gynecologist and a passionate teacher, Dr. P.C. Mahapatra sir. And all the previous episodes recorded episodes are available on our channel. Channel name is e-Gurukul Obstetric Gynecology by Dr. P.C. Mahapatra sir. It is a joint initiative of Juventus and Pracha Hospital. So all the recorded videos are available there. If you have missed any video, then you can go and you can subscribe to the channel and you can watch like a live video. And today's topic is also a very interesting topic. Today's topic is genital malignancy, radical hysterectomy, surgical options, tips and tricks. So without taking much time, I will hand over this session to Dr. P.C. Mahapatra sir. Welcome, sir.
Thank you, Dr. Sanjay, and the whole team of the Juventus under the leadership of Mr. Alad Mahajan. And again, we are back this month with the 26th episode. And therefore, I welcome to this e-Gurukul series. E-Gurukul is a familiar episode of all of us viewers and my lovable gynecologists across the country and abroad. And therefore, this 26th episode, till 25th, I was a benign gynecologist. Now I have to be a malignant gynecologist today from 26th episode. So thanks to my oncology partner, my friend, Dr. Giri, and my students, Dr. Janmeja, Dr. Manonjan, Dr. Bhagyalakshmi, Dr. Jita, and everybody for helping me in stimulating something on gynecological malignancy and helping me and initiating me and sharing their experiences also in this particular episode. From my personal behalf, I thank all of those. Although I'm a teacher for the last 40 years, oncology was not my favorite subject. But as a teacher, I have to deal with everything, starting from benign to malignant, adolescent to menopause, pregnancy to contraception, everything I have to do that. And as a teaching session in e-Gurukul, I thought I will definitely take help of those experts so that my viewers will be really benefited for that. Thanks to again all of them for their sharing of some of their work, even the surgical procedures also with that. And with that, we'll have just start the episode on gynecological malignancy. When I thought to deal with this, I had initially discussed that, yes, let me finish some of the benign things and then we'll go to malignancy. Even in a gynecological malignancy, the spectrum is so vast and so large that it's not possible to finish it within one episode for that within few hours. And that's why I've divided into more than one episode. And in this episode, I thought, let us concentrate on the uterine cancer, and which is a common thing. Day in and day out, you must be seeing and operating. And there are a lot of innovations for the last few decades regarding the concept, regarding the changing strategies of surgeries and the therapy and researchers. I'm not going to deal with the preventive part today because the theme is mainly a surgical skill transfer. And therefore, I bring greetings from the place Lord Jagannath. And this is a thing I will focus particularly on these two aspects, carcinoma cervix and carcinoma endometrium, and limit it, my talk or my videos to the uterine cancer malignancy. And the tips and tricks will be also enumerated in the videos for that. Well, when we come to the genital malignancy, I think the things will come about the world scenario and a comparative thing on Indian scenario. There is a changing strategies and the changing trends and the prevalence of these particular different varieties of genital malignancy. And we have seen that cervical cancer was really a great problem in country like India. And therefore more attention was given on the preventive oncology. And starting from the screening to the different preventive methodology of the innovative vaccines and all that. But surprisingly, I don't know why it has not been a proper utilized, particularly in a country like India. Who is responsible for that? Because we know that the HPV has become a very important part. 16 and 18 has been proved to be one of the important. About 70 to 80% can be prevented if we have an immunization protocol. But since last more than 1 decade, our gynecological oncologists are trying hard, even general gynecologists and the advocacy system, starting from FOXY to the Gynecological Oncology Society, they are trying hard to propagate and sensitize not only the community, but the doctors and gynecologist itself also. But due to some reason or other, the health policy makers and all that are not able to contract that. And we thought initially, when this remarkable hypothesis has come from the Nobel laureate, which started the HPV, and we thought that there could be a drastic change in that. For few years, I will show you how a difference from 18 to 20. I think when we come to 18, the statistics was a little better. We thought that the cancer of cervix has been declining, and cancer endometrium has been increasing. And this is I feel that I was really happy that yes, cancer cervix has been decreasing, but cancer endometrium, the prevalence is gradually increasing. In our general practice, there's a presumption, and the data also was showing that yes, endometrial carcinoma in country like India and developing countries also, in contrast to the developed countries, the incidence is gradually more, and prevalence we find more often the endometrial carcinoma. For years together, if you see, when we have not seen an endometrial carcinoma, but now for the last 5 years, we see endometrial carcinoma quite often. It's not less, and quite often. It could be due to the changing lifestyle, the corpus cancer syndrome, the diabetes, the hypertension, the obesity, and the longer health life of the female spending in the postmenopausal period, and with or without the therapy, the exogenous hormone therapy and all that. Whatever may be the reason, this could be there. But if you go to the statistics and the prevalence of this, this is a Globocon 2020, the world data, so that the new cases more than 6 lakhs. Cervical cancer and death is not more than, I think, half will be the mortality. And corpus uteri is also at par with that cervix uteri, although it is less, about 4 lakhs, and the death are almost around 1 lakh for that. Ovary and vulva, we are not going to be dealing with that in this particular episode. So these particular 2 things, I will just focus attention to that. And the new cases worldwide over the genital malignancy, total overall genital malignancy worldwide in India, this is the figure which I'm just presenting before you. And the comparative data between the world and India about the uterine cancer, cervix, corpus, ovary and vulva, comparative statistics just before my deliberations on this particular 2 very important aspects. Overall genital malignancy, I will focus on that. And when we come to the individual organs, cervix, utero, ovary, corpus uteri, and vulva, you see the difference between 2018 and 2020. The 2018, there was a drop, new cases almost less than 1 lakh. I think if you compare to the 2020, it has gradually increasing cervix, uterine cervix within this couple of 2 years. And we do not know, the data will come after 2 years in 22, what is the changing trends. But definitely, there was a drop in 2018, but gradually 2020, it has been increased. And same as for the corpus uteri, the new cases are 1,33,228. And now the corpus uteri also, the prevalence is increasing to 1,64,013. I think this is 6,413. So this is certainly a point of concern as we grow. And now we should think, and the researcher and scientist and clinician should think and corroborate with this prevalence rate, increasing prevalence rate, and cannot be kept quiet. We should find out and introspect and find out seriously what is the reason for that, and action taken by that. However, gynecological cancer, 45% of cancers in Indian women and 26% of all cancers, it accounts for that. And more than 25% of the bottom of the world's carcinoma cervix is still in India. And that is a long, I think this has given us really thinking how we must act aggressively to combat this particular graded carcinoma for that. So now I will just focus attention to that of the carcinoma cervix and carcinoma endometrium. When we deal with this carcinoma cervix, again, the growing inequalities of cervical cancer incidence rates global in 2020, we find that, and 2012, 2018, and 2020. And as I was just comparing between this last from 2012 to 2020, there is a declining in 2018, but again, there is an increase in 2020 for that. Now, a brief review of our knowledge regarding the carcinoma cervix. Everybody knows what is the situation. I need not make you aware of that, but still I want to emphasize because of the increasing prevalence and all that. And carcinoma cervix, as far as the malignancy is concerned, this is one of the malignancy, genital malignancy, where the extensive studies of the natural course of the disease has been very well studied. And if you go for the epidemiological part and the pathogenesis part, you could know that how the natural course of the disease for a long, long period, and therefore the need for either a preventive or a very early diagnosis for that. And as in all general malignancies, early diagnosis is the paramount importance as far as the survival rate, whether therapy by surgery or by chemotherapy or by radiation, whatever it may be. But this is very, very clear. The natural course of the disease, very, very clear for that. It has some distinct part of the cervical intraepithelial neoplasia. Then it goes to the pre-invasive and invasive, micro-invasive, and then invasive cancer in the different grades and stage of the disease. And that takes a long years for that to grow. And that's why we have really opportunities to target at that particular level before we find an advanced stage. In contrast to the ovarian malignancy, which is very, very difficult in that way. Now, again, I must reiterate that the significance of HPV, the 16 and 18, and the preventive aspects of this, and therefore this particular is really underutilized in country like India, and we must be sensitized, our beneficiaries must be sensitized, our healthcare policymakers should be sensitized for that, and that is really a lacuna, and still I find that we must continue pressing on the beneficiaries, on the healthcare providers to make it really implementable and for the benefit of the beneficiaries for that. And this is very important part, which I need not go to the details of the preventive aspects. The time doesn't permit me to elaborate the different preventive aspects. It has been already known to all of you for that. Now, as per the screening also, when we come to the preventive oncology part, the screening, there is also a changing trends and changing techniques. There are various, since the time of Papa Niccolo, the various modifications of this particular PAP staining technology, the media, and the role of colposcopy, and whether you go to a universal screening or at-risk screening, and screening by a combination with the HPV tests, all these are having a drastic change for the last at least 1 decade or so, and everyone must be aware of that. But the importance of I think the more sensitization of the gynecologist is necessary, and that's why I thought I'll give more importance on the sensitizing the gynecologist at their OPD level, how they will pick up the cases. Even we speak of the PAPs, how many people are really doing a speculum examination? That's not now in the era of technology. Mainly the sonography, endoscopy has replaced our 2 fingers and speculum and all that. I think this is the importance of gynecologist and speculum examination, and at least a visual inspection of with or without acetic acid. That's a very important part as a catch them from the early stage for that. And then go on stepwise, either a PAP or a colposcopy or a biopsy and all that. Now again, staging. staging of cancer cervix, if we say, when we were students, the cancer cervix staging, the FIGO staging was very, very popular. We got by heart the different stages of that. And now, if you compare, there's a revised staging also. And at this point, I will just congratulate and salute one of the Indian gynecologist, Professor Nirja Vatla. I think Vatla was one of the pioneer in the group of the task force in the staging of the FIGO staging and incorporated that. Well, what is the change in that staging for that? When we say that carcinoma cervix staging, mainly we are limiting to the days era where the diagnostic armamentarium was not available. We're just limiting to the either a clinical staging or a surgical staging for that. But before surgery, I think there could be some methods of staging so that prior to surgery, we can plan our surgery for that. Whether we can do the surgery or some alternative modalities can be done for that. And then there came some of the ancillary gadgets, like a cystoscopy should be there, like a sonography should be there for that. And therefore now the imaging science has developed a significant extent. And it is not only the sonography, but the CT, MRI plays a great role in outlining the extent of the disease. So MRI and CT. Now, if we differentiate whether which to choose CT and MRI, one must be very clear that the extent of the disease can be very well defined. The lateral extension, the anterior or posterior extension, local spread. I think MRI can give a better idea for that. But as far as the lymphatic spread or lymph node assessment, I think CT will be a little better than the MRI for that. So CT will give an additional information on the lymph node involvement for that. And of course, the PETs can very minute and distant metastasis cannot be picked up by the CT, where PETs can as definitely added to the adjunct as a diagnostic armamentarium, particularly in relevance to the stage of the disease for that. Now, as far as the therapy is concerned, multimodal approaches in therapy, if you see the history of the different stages of the disease, even surgery was recommended in stage 2B also. Now, gone are the areas where you compare with the radiotherapy modality has become advanced so well that it can be adopted for all stages. There is no doubt about it. And if you compare the 5 years survival rate is almost proportional for that. But the surgical limit has been defined, and surgical limit gradually we say that yes, it's always better for the stage 1 up till the very early stage, very early and early stage we divide into up to about stage 2B. Stage 1 and 2A is early stage and the rest is late stage. We divide into this variety, and of course in early stage only surgery has to be done. And no more we are seeing, I think it is not recommended, particularly when the parametrum is involved, you do a surgery, better shift to the radiotherapy. So the changing strategy in terms of surgical indications for that has become very clear cut. And therefore, particularly in the early stage, we devote to the surgical aspect as far as the benefit of the patient, 5-year survival for that. Now, therefore, again, the selection of cases for surgical options, the selection of cases, I think that should be there basing on these parameters and the history examination, and of course the investigations will aid and help all of us in selecting the cases for surgical options for that, the candidates. Now the surgical procedure, there is a changing trends and changing techniques. And when the minimal invasive surgery has come up in a big way and now expanded into the horizon of the malignancy, even in India and abroad also, the enthusiasm came for the endoscopic surgeon to enter into the subject of carcinoma cervix. And for the, particularly for over one decade, there has been studies of that and done that. And the last LSS trial, that is really given a hint to the restriction of the laparoscopic procedure, particularly in cancer cervix for that. So this trial, extensive trial, demonstrates that laparotomy is definitely superior to the laparoscopic approach when carcinoma cervix is concerned for that. And still the AAGL and other people are finding subtypes and in-depth analysis as to why this trial, what is the problem in the trial, whether it's a independent surgeon oriented, I think the surgical skill oriented, or some in general for that. But still, at the present setup, the message goes that yes, laparoscopic for cancer cervix, please hold it for that till we find a rewind, I think a new trial and find out the clarity of the situation, whether endoscopic approach could be there for that. And therefore, here, when we combine with the carcinoma cervix and carcinoma endometrium, the surgical modality is very, very clear for that. There is definitely scope for endoscopic route, particularly when deal with the carcinoma endometrium, but not in cervix for that. And the details of the controversies and the consensus, particularly as regards the LSS trial, one can go and find out what are the problems for that. Again, robotics is there. Robotics is now an accepted thing for particularly in oncology. There's no that robotic is not for benign disease. Even the extensive studies by individual, by institution, or evidence always by RCT also, it shows that yes, it's not that robotics can be used for a simple hysterectomy for that. I think gone are the days where this is accepted fact that for simple hysterectomy for benign conditions, no to robotics for that. And you can go, but robotics is there indicated for gynecological malignancy, only in a case of laparoscopic, because particularly when we speak of cancer cervix, say no, but cancer endometrium, definitely there is a place for if you either a laparoscopic hysterectomy or a robotic hysterectomy, choice is yours. Of course, the robotics has additional advantage for as regards the ergonomics, as regards the 3D visions, and as regards the your comfortability of exposure for that. But the choice is depending on the particular individual persons whether to select a robotic or the endoscopy. But endoscopically also you can do equally well, laparoscopic equally well as compared to the robotics, particularly in carcinoma endometrium. But say no, till today the message is that
Adi sir's voice is video is stopped or what?
I think so. The signal loss हुआ है, मैं कॉल करता हूँ.
हाँ सर को बताना पड़ेगा, डीडी को फोन करना पड़ेगा नहीं तो. Admin.
I'm calling the.
Yeah.
सिग्नल लॉस हो रहा है, वापस कर रहा है.
हाँ मेरे ख्याल से पार्टिसिपेंट में से भी निकल गए हैं वो.
Control just like Bernard did is enough. We have lost control and sorry connection and restore soon.
बात हुआ आदि डीडी से. I think sir has come back. Sir has come back. Connected दिखा रहे sir. Sir is showing connected.
1 second, we are just logging in.
Yes, sir. Yes, sir.
Got a minute, sir.
So you are audible now.
Screen sharing the coordinates. पंचायत कैसे गोटे सेकंड Can we start?
Yes,
Can we
sir.
start now?
Yes, sir. Yes, sir.
Is
Yes,
the
sir.
screen visible?
Yes, sir.
Yes, sir.
Sorry, my viewers. Sorry, Juventus team, for the interruption. I know that I don't know anything about digital technology and all that, but due to some reason, it is automatically got stuck, and I think now we can start again. So, surgical procedure, there is a changing trends and changing techniques, and the endoscopic versus laparotomy, non-endoscopic techniques. The carcinoma cervix is very, very clear unless we get a refination and again a trial showing that yes, endoscopy we can do for that. Now, a little bit about the surgery for pre-invasive disease. The pre-invasive disease, there is a surgical options. There are two surgical options for that. One is an ablative procedures, another is an excisional procedures. In ablative procedures, we have got a long years of cryotherapy and carbon dioxide laser therapy, which is there. But the excisional procedures like a cold knife conization. Conization is still one of the method in very pre-invasive or even in very, very early invasive stages, particularly when it is limited to the micro-invasive stage 1A1. And loop electrosurgical excision procedure has become popular, and particularly is also limited to the pre-invasive disease and a very, very early invasive stage for that. And these are the stages. I need not emphasize that because in the carcinoma cervix, there are stages starting from the 1, 2, 3, 4, and there you must find out what is the depth of stromal invasion and classifying into the different subvarieties, and the tumor and the growth, the size of the tumor, the dimensions of the tumor. It also plays a great role in form of the staging of the disease. And of course, we know that the squamous cell carcinoma is a predominant variety, about 80 to 90%, than the adenocarcinoma and other rare varieties of that. And this is as per the local spread and the lymphatic spread, which is there in the stages. So therefore, to sum up, again to highlight and the figure 2018 staging of carcinoma cervix ureter, where our own Indian gynecologist, Dr. Nirja Vatla, has contributed a lot and his opinion for that. We have been dividing this particularly. So why we are going too in depth for that? It's very simple: stage 1, stage 2, stage 3, stage 4. But the sub-classification gives us an idea about the particularly the microscopic or very early differentiation, so that in some cases we can go that yes, non-surgical management, I think, shifted to the chemotherapy for that. And some cases very early we can go to a more conservative procedure. So these are two extremes in this case for that. And therefore, for some of the cases of fertility sparing, some of the cases where the young carcinoma cervix in young, we want to conserve the uterus. So even if it's a case of very early cancer, we must find out for that. So therefore, stage 1, we know that it is confined to the cervix. And of course, the corpus extension is disregarded as because it doesn't going to any prognosis for that. Now, stage 1 again is divided into A, B, and A is divided into A1, where A is invasive carcinoma that can be diagnosed only by microscopy with the deepest invasion of less than 5 millimeter. And this 5 millimeter we divide into the A1 and A2, major stromal invasion of less than 3 millimeter A1, and A2 major stromal invasion of more than 3 millimeter, 3 to 5 millimeter is A2 for that. So this particular variety, as I was telling that yes, it could be dealt with the more conservative procedures. Its radicality is not to be manifested here. Whereas the 1B, B is divided into 3 particular segments, 1, 2, and 3. And there the size of the thing is important, and it's less than 2 centimeter dimensions, from 2 to 4 centimeter and more than 4 centimeter. This is the different variety. So the size of the growth is important, particularly in the 1B for that. And the microscopic spread is more important in stage 1. And stage 1A, particularly limited up to less than 5 millimeter. When it is crossed more than 5 millimeter, it is reached to stage 1B. And there we divide into the 3 mainly, because the prognosis also varies as far as the tumor volume is concerned, the size of the tumor. Stage 2, carcinoma invades beyond the uterus, but has not extended into the lower third of the vagina or pelvic wall. And here we find A, B, and A, stage 2A involvement limited to the upper 2/3 of the vagina without parametrial involvement. And A1 is again a size, invasive carcinoma, the size less than the 4 centimeter in greatest dimensions. If it is more than 4 centimeter, then it comes to be A2. Whereas 2B is mainly parametrial involvement, and but not to the pelvic wall. And stage 3, the carcinoma involves the lower third of the vagina and extends to the pelvic wall and causes hydronephrosis, non-functioning kidney, or involves the pelvic or para-aortic lymph nodes. So stage 3B earlier was yes, when there is no cancer-free space from this parametrium and from the right up to the lateral pelvic wall, we defined as a case to be stage 3. But here it is very, very specific, elaborate, that A, B, C, and in C has been divided into 2, 1 and 2. And A is carcinoma involving the lower third of the vagina with no extension of the pelvic wall. Whereas B, extension to the pelvic wall and or hydronephrosis or non-functioning kidney. And this is stage 3B. But stage 3C is either involvement of the node, pelvic node, or a para-aortic node. When the pelvic node metastasis only is there, it is C1. Whereas the para-aortic node metastasis is there, is C2. I think these has grown up, the subtypes are there because of the diagnostic gadgets like a CT scan, picking up the nodal metastasis, evidence of nodal metastasis come out in view for that. And of course, this is some additional stages or definition by the technology when we are improvised technology on the imaging science, particularly for that. And of course, stage 4 extended beyond the 2 pelvis are involved. The mucosa of the bladder or bullous edema doesn't permit a case to be allocated to stage 4. And A is adjacent organs, the pelvic organs, and distant organs is 4B. There is not much of change as far as the previous PIGO classification as far as the stage 4 is concerned. Now, frequency of metastasis. There is a correlation between the metastatic metastasis of pelvic nodes associated with the stages. These are some of the frequency where we say that commonly we believe that earlier the stage, less is the nodal metastasis for that. But if we consider that we are contemplating this surgery for hysterectomy, the radical surgery for that, we should know that which stage, even we operable in early stage also, the metastatic, I think the frequency is up to about 2 to 9 in stage 1A2, and stage 1B 12 to 20% frequency for that. And frequency of metastasis is para-aortic. When we're not thinking of, we're restricting to pelvic nodes and earlier, but now the para-aortic nodes involvement, particularly in we were thinking that it is mainly restricted to the ovarian malignancy and some cases of endometrial malignancy for that. Now in cervical cancer also, para-aortic nodes has been frequency of metastasis with the stages. As the stage advances, of course, it is list with the 4 to 7 in stage 1, but in 4, 3 and 4, it goes to about 25 to 50% of that. Now, surgical treatment for very early cancers, as I was told, apart from the pre-invasive variety where we do an ablative procedure or excisional procedures, These are for a very early cancer like cervical conization, simple hysterectomy with nodal assessment, and fertility sparing radical trachelectomy. This point I was telling that even if it is a invasive cancer and it is a very early invasive cancer, there is a place of conservative procedures if the patient is very young and desires the fertility for that. And therefore, this particularly the Sloan Kettering Center was the innovations for that and proposed the radical abdominal trachelectomy. Before the radical abdominal trachelectomy, vaginal trachelectomy was also been practiced, and these Sloan Kettering has emphasized and particularly given importance to the details of the surgical procedure and popularized it for the purpose of reproduction, for fertility promoting surgery for that. And here what happens, you have to remove the in a very early stage like stage 1A1, there is a place for removing only the cervix, the part, and the only thing is that you remove that part, but a shaving zone, that's called a saving zone, which is being there, you send it for biopsy to find out the remnant of that disease portion organ is there or not, and then stitch it with this, they oppose it with the uterus is opposing with the vagina, with or without a circlage. I think the initially the non-absorbable suture has to be used for that, and this is a revolution of the cases which is not very popular all over the globe, but this Sloan Kettering Center has become one of the pioneer as a radical trachelectomy for that. Now this I will show you particularly. This is a case I think my friend Dr. Giri has was practicing for that, and conization. So the indications could be many. So disparity between the cytologic as well as the histological finding with or without the colposcopy can identify which are the candidates selected for this purpose of conization. It could be a diagnostic, it could be a completely therapeutic element, particularly in some cases for that. So a brief video on this particular conization, where the technique is not very difficult procedure. Any one of you can do it, the procedure for that. Initial hemostatic infiltration has to be given, and identification, just a cone of the cervix has to be given, and then send it for HP study, the margins, so that we can know whether it has been completed or not, or still some of the pathology is there, some of the diseased entity is there for that. And of course, the bleaching, then comes the cauterization, with the diathermic coagulation with that for the bleeding, and then the stitches, serial stitching, the suture, serial sutures will be done all around the circumferential suture again for bleeding for that. So these are very rare entity, but still there is a place we find such very, very early stages for that. This was earlier practice for the pre-invasive variety, or even in a case of this CIN, some of the cases for that. But this could be adopted when we want to conjure the uterus because of the age, because of the desire for fertility. This is one of the methods where we can do it, procedure of choice for that. So this is not a bygone days. It's really a very surgery which is very, very alluring for that. And this is one which a video by Dr. S.K. Giri has been submitted to me. I will just show it for that. Now, then comes the radical hysterectomy. The evolution of radical hysterectomy, I think two names come to our mind. Very importantly, from Vienna, the two schools, the Verdim, Dr. Verdim, and then Verdim's hysterectomy has become very popular since 1895. And of course, the friend Schauter has again devised a less morbid and a less invasive procedure in the vaginal hysterectomy, radical vaginal hysterectomy. So abdominally, the procedure, though Bonney and Mix have extensively studied and with the devising the concept of this technique, and Verdim's has become very popular in publishing the first publication of that, and therefore the abdominal procedure has been in name of the Verdim, and vaginal the Schauter. These are the two schools where it has been propagated and for the radical hysterectomy, which has been accepted till now also. Now, our Indian contribution for that, added to that, Professor Subodh Mitra's modification of that technique also, again, combined with a vaginal hysterectomy, radical vaginal hysterectomy with bilateral inguinal lymphadenectomy, on the two sides for that. That has become a modification of the different radical procedure for that. Now, basing on that, when the endoscopic gadgets has become really popular, and more and more of the endoscopic surgeons and a brilliant endoscopic surgeons in the country like India also, as well as abroad, have really focused attention on cancer, the cervix for that. And therefore, they started, till the LSCC trial has concluded that there are some demerits of that and they're inferior to the laparotomy for that. And therefore, the controversy versus consensus continued for quite a few years. And of course, now the present status, again, I'm telling you, I'm just concluding that for carcinoma cervix, I think the laparotomy has become an age over the laparoscopic procedure, but laparoscopy has definitely advantage over the when we come with the endometrial carcinoma for that. Again, I have clarified the role of robotics for that. Now, as far as the hysterectomy is concerned, with special relevance to oncology, we have divided into the different classes of hysterectomy, the 5 classes of hysterectomy. The class 1, simple extrafacial total hysterectomy, and is performed for treatment for stage 1A1 disease. And class 2, also known as a modified radical hysterectomy, which removes a more generous vaginal cuff, ligates the uterine artery on the medial side of the uterus, but doesn't dissect the ureter from the vesicouterine ligament, and removes the inner third to 1/2 of the cardinal ligament. And some surgeons recommend the class 2 hysterectomy for stage 1A2 cervical carcinoma. And class 3 is the classic mixed procedure, including the removal of the entire parametrium and paravaginal tissue, as well as the pelvic lymph nodes. And class 4 is a radical hysterectomy and more extensive procedure where the ureter is completely dissected from the cardinal and vesicouterine ligaments, the superior vesical artery is sacrificed, and 3/4 of the vagina is removed. The uterus and parametrium are removed, and a complete lymphadenectomy is performed for that. And of course, stage class 5, a radical hysterectomy and far more extensive procedure in which the terminal ureter or a segment of the bladder or rectum is removed along with the uterus, parametria, adnexa, and pelvic lymph nodes. When we were students, I think the exenteration operation we were reading, and it was divided by Brunswick. And the exenteration operation, either anterior exenteration with removal of the bladder and the ureteric implantation to the ileum, or the total posterior exenteration, or when the posterior involvement is there, the rectum, and then diversion of the colon and diversion of the GI system, and total exenteration if everything is there in extensive in place. So even in stage 4, stage 3, stage 4, exenteration was the operation at that time. It was an experimental. I think it has been settled that there is no place for exenteration now, vis-a-vis when the radiotherapy is really gives a equal or more than better survival rate and comparison to the surgery. I think this is an advanced stage. It should not be a surgery, and this should be contraindicated and shifted to the other alternative modalities like radiotherapy and chemotherapy. Now, these are the, I have given, what are the different steps, what are the difference between this involvement of the tissues in relation to the different procedure or the different classes of hysterectomy. In a simple hysterectomy, there are 3. I think you must be able to know what are the 4 organs or 4 involved tissues: parametria, paracarpus, uterine vessels, uterosacral ligament, and the vagina. And if you compare the different classes, simple hysterectomy, type 1 hysterectomy, the parametria and paracarpus, you preserve it. Uterine vessels are ligated at uterine isthmus, and uterosacral ligament transected at uterine insertion, and vagina is a preservation. I think this is a simple hysterectomy, which very, very early cases we do it in malignancy. Now, modified radical hysterectomy is type 2. The parametrium, the paracarpus is removed medial to the ureter. Uterine vessels are ligated at the level of the ureter, and uterosacral is transected midway between the uterus and rectum, and remove 1/3 of the vagina. And radical abdominal hysterectomy type 3, removed medial to uterine vessel origin is the parametrium, and paracarpus, uterine vessels ligation at origin of internal vessels, and uterosacral ligament transection near rectum, and remove the vagina little more than the type 2. Type 4 is removed medial to the uterine vessel, is the parametrium, and ligation of the uterine artery vessels at the internal vessels, ligate superior to vesical artery, transect near rectum, and remove the vagina more. Type 4 is removal. Type 5 is removed medial to uterine vessel origin, ligation at origin from internal vessels, ligate superior vesical artery, and transection near rectum for that. When we come to the radical vaginal hysterectomy, it is divided into the medial to ureter is the parametrium and paracarpus, ligate at the level of the ureter, the uterine vessels, partially remove the uterosacral ligament. And in radical vaginal hysterectomy, you can define the vaginal extent of the lesion for that. That's an added advantage for that. But at the same time, the ureteric knuckle has to be identified. It is technically a little difficult for that. And therefore, there is a place of the radical vaginal hysterectomy. I think it has almost gone to the graveyard now, where I find that I remember Dr. N. Rai Chaudhary was doing in India about that, and the vaginal hysterectomy, radical vaginal hysterectomy. And I don't know why it has been not a revival of this radical vaginal hysterectomy. There is a thing that, yes, I was thinking as a vaginal surgeon that there should be a revival of the vaginal route, so that for the morbidity part, it could also corroborate with the laparoscopic approach. I think the gynecological oncologic surgeon will take up these issues and go ahead with that. When we come to the radical vaginal trachelectomy and radical abdominal trachelectomy, radical abdominal trachelectomy is little superior to the radical vaginal trachelectomy as far as the upper margin, and therefore that is important. And even with the upper margin, the saver margin has to be done for that, and that has to be sent to the histopathology for evidence of the leftover tissues for that. Now, as we go more and more in 2018, Dr. Quellu and Maro gave a Japanese Kyoto classification and alternative classification. This is what is the basis of this mainly Kyoto classification by Quellu and Maro. This is based on the two important concepts, whether based on lateral extension of the resection and extent of the resection and lymph node dissection separately. Now, the paracervical and parametrium, the lateral tissue limit of extent of resection is important, where type A is minimum resection of paracervical tissues, whereas type B is transection of paracervix at the ureter. And B1 and B2 divided whether without removal of the lateral paracervical lymph nodes or with removal of the lateral paracervical lymph nodes for that. And type C, resection of paracervix at the junction with the internal vascular system, and again C1 with nerve preservation, C2 without nerve preservation for that. And type D, the entire paracervix is resected. D1, resection of the entire paracervix with hypogastric vessels. D2, resection of the entire paracervix along with hypogastric vessels and adjacent facial and muscular structure. I think the different classification system and the extent of the lesion is to find out, to preserve the post-operative functions, the bowel, bladder, the sympathetic nervous system for that. So therefore, the nerve sparing surgery has become an additional concept incorporated to the radical surgery and radical hysterectomy for that. So a brief review of the treatment of plan for cancer cervix. If you find a stage 1A1, simple hysterectomy preferred if childbearing is completed or survive. There is a place for cervical conization. That's why I put forward this video. That is very A1. There is a place for cervical conization for that. And stage 1A1, again, one of the prognostic factors is a lymphovascular space invasion. And if it is there, I think more radical procedure has to be done for that. And therefore, in that particular case, if there is a LVSI is there, modified radical hysterectomy with pelvic lymph node dissection. And of course, there is a place for the sentinel node biopsy, which is more important, more applicable for more practiced for endometrial carcinoma than in case of carcinomas. But there is a place now that there are many authors, many people who are doing that sentinel node dissection. The purpose for which this is done, that we know that as we go, the lymph node involvement, a correlation I have shown that very early very early disease, even no lymph node metastasis is there. So if you confirm it before it by the sentinel node dissection, I think the morbidity part is job, and don't limit a surgery. No, a very extensive surgery has not been done. It's a modified radical procedure, or at best we can do a conservative procedure like a modified trachelectomy and pelvic node dissection for selected patients desiring a fertility for that. And A2, radical hysterectomy plus pelvic node dissection and radical hysterectomy plus PLND for selected patients desiring fertility, trachelectomy for patients desiring for fertility for that. 1B1 to 2A1 is a radical hysterectomy plus pelvic lymphadenectomy. And if the tumor size is more than 2 centimeters, is less than 2 centimeters, you can do a sentinel node biopsy for that. And radical trachelectomy is again, some people have tried for selected patients, but the message is that only will limit it to the very early stage of stage 1A1, and rest of the cases we do a radical hysterectomy because the prognosis is not very well and the results are not very well for that. And of course, in a bulky uterus, stage 1B3 to 2A2, the chemoradiation and pelvic exenteration rarely perform for that. Too many, it's a more of surgical excellence and demonstrating the surgical excellence, not for the benefit of the patient for that. And of course, we cannot forget the role of chemotherapy and radiotherapy as a palliative method for that in very advanced stages for the cancer service. So whatever it may be, basing on this concept, we know that and as a surgeon, we are going to adopt the radical procedure, and therefore preoperative assessment is important, preparation is important, and counseling is important for that. And believe me, I must say again that when we go for a radical procedure or a malignancy, it's not a casual surgery. The persons who are habituated with that, I think oncosurgeons, they must be treated because the primary surgery is very, very important for that also. You can learn it and then you can do it, but it's not the prerogative of all gynecologists to do that for that. You learn it properly under supervision and under guidance. And therefore, I must give a message that yes, when the subjects of specialty of gynecological oncology has grown up like anything, and in the country like India also, the people are very expert in that, and regularly, if a person doing regularly this procedure of radicality will be more better and results will be much more better. That's my impression, and that's my concept for that also. And therefore, when a radical procedure is there, the assessment should be very, very meticulous. Preparation should be little more than a benign. And of course, the counseling. You must do counseling is a part and parcel of all procedures, but here it's important for that. Now, as far as the surgical techniques, the steps starting. So initially, these are some of the steps you must keep it in mind. What are the different steps? Distinct steps of the procedure of radical surgery, radical hysterectomy, incision. What is the type of incision you must give? The exposure is very, very important. And this is one of the extremes, endoscopic, a keyhole surgery, but versus a big hole surgery versus a very big hole surgery. I think this incision is important for that. I always have a debate with my friends that yes, if the incision has gone beyond the umbilicus, I was a little irritated for that. Because I always believe that transverse incision, but transverse incision, there is a place for transverse incision and muscle cutting incision for that. So you can do a good exposure in particularly the radical hysterectomy limited to the corpus or to the cervix for that. Not for ovarian, but at least there is a place for transverse incision and you get a lot of benefit out of it also. And that I will advise you, particularly in selected patients of obese patients. And there's certainly some benefit of it. But definitely a muscle cutting incision should be given for that. And after that, before contemplating any procedure, the abdominal exploration is important. You must visualize because this is an additional stage. The surgical staging has to be incorporated for that. And abdominal exploration by inspection, by palpation. And this is very, very important as far as the operability is concerned for that. Assessment of operability, whether the uterus is mobile or not, whether there is extent of the lesion above in the pelvic structures or pelvic organs have been affected for that. And therefore, this is important. Abdominal exploration is important and assessment of operability. And this is particularly not only by inspection, but even at that time when operability was only the gadgets was not there, the recommendation was there. that whenever you are going for a radical surgery, first open the UV space, uterovesical space, see that the bladder is there. And that is the part when the bladder is not properly mobilized and you find that there are resistance, stop the procedure and do some alternate methods for that. I think this is one of the very important things for the benefit of the patient. Assessment of operability is an essential thing in the procedure and the steps of that. Now, the pelvic space and oncology has become very, very clear cut now. When laparoscopy has come out, this has given a lesson for all of us to find out the creating the spaces for that. Before endoscopic procedure also, they were dissecting, but the main visibility and the propagation of the different identification of the different spaces not very, very clear. Now, as far as the pelvic surgery is concerned, as far as the radical pelvic surgery is concerned, two very important things: a less vascular space you have to identify, the paravesical space and the pararectal space. These are two important space which is there, so that if you enter into that, dissection becomes very simple for that. So this is a very important design, the limits of the paravesical space, limits of the pararectal space, you dissect it and enter into it. Ligation of the infundibulum pelvic fold and round ligament is the next part. Then lymph node dissection. Again, lymph node dissection, what is the pelvic node lymph node dissection? What is the upper end? I think it is the mid-common iliac. The mid-common iliac artery is the superior part. And what is the limit of the inferior part? It is the circumflex vein, internal circumflex vein crossing over the external iliac. I think these are the two limits, and in which we go that. And the deeper limits is an obturator nerve, I think before that, and none is there below the obturator nerve for that. And whatever is there is that above the obturator nerve and lateral to the obturator nerve is there. So this basic concept of the anatomy is important in form of a radical procedure for that. And you go with the lymph node dissection. And believe me, there is a change in the surgical procedures from yesteryears to the present years for that. Yesteryears, by choose the node, remove the node, pick the node and just remove it. But here, I think in chain you have to remove it. You start from the lower part and remove it and block. This is important. This is possible also. It's possible by the skilled surgeons. I think even average surgeons can do the procedure, but the chain, you have to remove the chain, and the chain includes the first, we know the anatomy of the lymph nodes in relation to the cervical drainage of the lymph nodes from the cervix and uterus. We know that the obturator is important, the internal iliac is important, the external iliac is important, the common iliac is important. Of course, beyond that, you go for the para-aortic for that. And the parametrial and presacral are again the two small nodes. You search for it and for removal for that. So this is all a basic evaluation of the lymph node. Anatomy of the lymph node is important, and the draining lymph nodes, you must be able to dissect it and block for that. Another important dissection is the dissection of ureter. The dissection of the ureter, again, the change in the concept is that whether skeletonization of the ureter or a periureteric fiber should be there for that. We have seen fistulas, if you skeletonize the ureter for that. Periureteric fiber muscle is important, but there is a lot of controversy here that absolute skeletonization is not at all necessary for that. You have to free it medial to the broad ligament and the peritoneum and keep it lateral. It's absolutely possible for that if you know the anatomy for that. And remember, the angle of dissection should be in the course of the ureter. If you go in the course of the ureter rather than the horizontal part, you are not in trouble for that. If you are horizontally dissecting, and there could be a problem for that. You just dissect it either by laparoscopy, or if you are doing a endometrial carcinoma, or by open surgery also. With that Caesar dissection, you can go and find out till you find the uterine crossing is the transverse part for that. And that is the limit for which you can completely dissect starting from the pelvic brim downwards for that. So dissection of the ureter and the complications occurring at that particular level could be there, and the dissection next. Then the bladder dissection, because we are going to take a vaginal cuff and vaginal length also, so bladder dissection should be little more than that, and therefore a good plane of cleavage from the cervix and the vagina, upper vagina, has to be done. And the bladder dissection is not a very difficult job for that also. And of course, you identify it's a the uterine vessels and just ligate it for that. Then the dissection of ureter. This is a very important part. Right up to the level of the cardinal ligament, ureter dissection is not very difficult because you have to just dissect it. Only thing is that when the uterine artery has been ligated, then it comes, the cover is the content. There some of the veins are there. You must be very, very careful at the junction of that particular thing. And that's called a ureteric tunnel. It is a misnomer. It can be a misnomer, but many people do not believe that it's a tunnel should not be there. But definitely there is tissue around in the close to that, in the lateral angle of the vaginal wall, before the entry into the bladder for that. And therefore, dissection of the ureter from the cardinal ligament is absolutely necessary. And if it is a well dissected ureter, right from the pelvic brim to the insertion to the bladder, I think it could be very clearly dissected for that. And therefore, if this is a very important step. Then open the the posterior dissection, the rectovaginal septum, you have to dissect it. Remember, there are veins in that particular area. You enter into the denunvalus fossa, and still I respect the concept of the fat belongs to the rectum, fat belongs to the bladder. So if this concept is there, you are in the right plane for that in the posterior section, because you have to dissect it much more to bring quite a good length of the vagina for that, and the lateral parametrium dissection of the uterosacral and the cardinal ligaments for that. And therefore, then the next step comes to the transection of the uterosacral ligament and the cardinal ligament. And then you enter into the transection of the vagina and closure. Here, you remember the Bonnie's, the Werdim's clamp for that at that level. But normal clamp can do it also. Even with the vessel sealer system, you can do it also. And with the vessel sealer system, it's become so popular in malignancy that one is really going for that till they go for the vaginal closure and the vaginal closure for that. And the vaginal closure could be again a suturing, because the hemostasis is there, and anterior all throughout a running suture and locking suture can be there, so that the drain can be left in between it, or you can give the angle and then subsequently the middle. You can gonna the day we are routinely giving a drain. You can say normal patient's surgeon's choice, individual judgment, we say, but the drain is absolutely the decision of the surgeon for that. But hemostasis, this is in this era, the majority, I think, is the extensive surgery in the pelvis. If you are going to the proper space, identifying the structures there, absolutely it is bloodless. But generalized oozing, if it is there, the hemostasis should be maintained. We have a really a unique electrosurgical principles and practice, apply that. And gone are the days where every vessel has to be dilated. The concept of electro-ESD has not been devised for that. There was a problem. But basic thing is hemostasis has to be maintained for that. Now, this is a case. Now, going to this video, this patient presented to me, these are cases where there is a prolapse, and along with there is an anteriorly, there is a growth. And second degree descent with the growth, a 45-year-old lady, Paras, and we decided that yes, it's a parable stage, and the growth dimension is less than 4 centimeter. It's about 2.5 centimeter, and then we plan for that. The first and foremost is an exposure and analysis and pre-operative assessment. The surgical after that intra-abdominal assessment of the operability, the mobility, the identification of the different space and posterior and anterior. Then we enter into this particular IP ligament and the round ligament for that, and then enter into this the paravesical space and exposing for that. This is a paravesical space and pararectal space. These are the two main things we divide and proceed for that. Identification of the ureter, and then at this level, you just after identifying the ureter and the dissection, the uterine artery. So uterine artery at the origin, you find out and ligate it, and either you can ligate it or you can coagulate it also with the vessel sealer. Now vessel sealer has been used for coagulation for that, and the ureter has become very clearly delineated, and you go, then the ureter dissection could be there for that. You can know that hemostasis is being maintained, and here the so-called ureteric tunnel, which we say is there, and you must dissect it. With that ureteric tunnel is just in front of the ureter, and that is a part which you call it. And now, after the bladder dissection, corresponding bladder dissection, a proper cleavage, we can go right up to the level of the ureter. Then the posterior dissection starts, and the posterior dissection at the posteriorly opening the denumerous fossa and find out the pad from the two uterosacral for that. So from both the uterosacral, you find in a very less vascular space, because this is a very important. If you alter the space, you find a torrential bleeding from the veins. So enter into the space, the fat, I think posteriorly and in front. We deter that. If there is a small amount of bleeding, you can coagulate it or suture it for that. And then we can go and remove it. This is the cardinal ligament and the parametrium which is there. And with the clamp, you can also do the remove it with or without the suturing after that. Normally we place a clamp and then cut it and then suture it with that. You can use the vessel sealer. There is no problem for that nowadays. With the vessel sealer also, it's a very effective thing for that. So for that, we go anterior dissection quite low, posterior dissection quite low, and then only we can find out the lateral extent, the parametrial dissection, and therefore now the vagina has to be opened and cuffed, and then the last phase of the removal of the uterus for that. So this is a step which after that you evaluate and find out the extent of the lesion. You find out whether there is a cancer-free space there from the vagina, and you can take ask that there's upper margin of vagina, specifically see that whether the evidence of the histopathologic evidence of malignancy is there or not. And then the vagina, you can go and continuous, this is giving a continuous suture. And my friend Dr. Giri is very familiar with this type of thing. We have tried a lot. We have seen giving a drain also. Earlier we are giving a drain always to the vagina, and then change the concept that drainage should be there. Now the next step is the this is say the en bloc removal of the lymph nodes, starting from the lower part and lowest part in the circumflex iliac vein crossing. That is the limit, lowest limit. And then these are the bunch of the gland which is on the external iliac. The external iliac, the different chains of the external iliac, the lower and upper external iliac is there, and you can really skeletonize the vessels for that. And here again the bipolar helps us very well for that. And then retract the external iliac vein, and external iliac vein we find out, yes, this is a space where entering into the obturator and internal iliac group of lymph nodes for that. And once you find that the obturator nerve is there, below it there is nothing, no gland is there below it and all that, just separate it. And this is a guide, obturator nerve is a guide for that. And with the good bipolar technology, with that this also helps in dissection of the lymph nodes for that. So this is an obturator fossa where they were absolutely clean and it has removed it. And same thing we are doing with the opposite side for that. And this is a area where there is a chance of injury to the vessels also. And if there is a vessels injury also, the gynecological oncologists are not afraid of that. Here you find the evidence of initially we have palpated also, and we find that there is a large gland which is there sitting over the external iliac vein and over the obturator fossa for that. So this gland has to be removed. This is definitely presumed to be a positive gland for that. But at times, because of the fibrosis, but if it goes in a proper plane, everything can be enucleated with that. And the whole procedure is completed. If a delicate dissection is there with the concept of maintaining the strict hemostasis. And of course, the electrosurgical procedure helps us to serve the purpose for that. And that is the end of the story, where we completed the radical hysterectomy and with the pelvic lymphadenectomy for that. And then you close the abdomen and the surgery is finished. You can send it whole specimen, the glands, the vaginal age, and the whole specimen, the parametrium, everything, you send it for the histopathology. And then subsequently, you plan it whether there is a need for the adjunct therapy of chemotherapy, the radiotherapy or a chemotherapy for that also. And normally in cancer cervix, we do not go for the para-aortic involvement, para-aortic nodal resection, mainly for some cases of endometrial malignancy, and particularly for ovarian malignancy, this is mandatory for that. I will just show few cases for that. So a good chunk of the parametrium, we have removed it. A classical radical hysterectomy, the uterus, the adnexa, the upper 3 centimeter of the vagina, and the free edge is removed with that, and good amount of parametrium is removed for that. So the principles of surgery, first and foremost, is radicality. Radicality is the very important. You don't compromise the surgery for that also. That is important. And prevention of the injuries to the vessels, prevention of the injury to the viscera. The prevention of the injuries to the viscera or organs, there are 3 organs which is liable to that: bladder, ureter, and rectum. And of course, the great vessels are there. There is injury to vessels prevention. Prevention is a very important thing. And maintaining hemostasis is important. Prevention of sepsis is there. You can give an antibiotics, long-acting, the stronger antibiotics, a broad spectrum for that, because it's a. And if a patient is obese, you can put the other low molecular heparin for thromboprophylaxis for that. Now, this is important, the prevention of lymphocyst. Very often we find post-operatively, we find a lymphocyst in this radical surgery of cervix or endometrium for that. So lymphocyst is really a problem for that, and the drainage has to be given for that. And for that drain, as long as the drains, we find it for that. And of course, it confuses with the early recurrence, the left upper for that. But usually it is the lymphocyst which is being picked up by post-op sonography for that. It is not necessary. But the brain, if the lot of collection is there draining, I think you keep the drains maintaining for that till the collection comes down for that. And of course, there is no special post-op management in form of radical surgery, excepting the antibiotics, but nowadays it's very, very simple for that. Even parenteral fluids are not necessary more than 36 hours or maximum 48 hours for that. And patient is ambulatory the next day onwards for that. Now, the second important concept, will target for the endometrial carcinoma. Now, endometrial carcinoma, there is also an evolving trends. I have already told from the beginning that we have only seen, early days, only seeing the carcinoma cervix. We are finding when in a couple of months, 6 months or 1 year, we find one case of endometrial carcinoma. Now we are finding every month I find a carcinoma cervix as well as carcinoma endometrial. I was thinking that yes, there is a increasing in prevalence of the endometrial carcinoma. Yes, I feel that there is an increased incidence of endometrial carcinoma because of the longevity, because of the metabolic diseases, and because of the hormones for that. There is an evolving trends for that. Now, therefore, the risk factor in a patient profile is important, and a postmenopausal, they usually present with the postmenopausal bleeding, and in a postmenopausal bleeding, the risk factor could be diabetes, could be obesity, could be hypertension, and this is all corpus cancer syndrome. And of course, with or without the history of exogenous hormone profile, hormone therapy, or feminine forever for that. These are typical patient profile for the endometrial carcinoma. The diagnostic gadgets. Gone are the days where a pre-sonographic era, a postmenopausal bleeding, the first and foremost, we think that it could be ruled out the endometrial carcinoma. And we used to do the DNC, blind DNC. Then the concept came, the blind DNC, we are ignoring, we are missing some of the cases. So the fractional curettage was at that time very, very popular. So the different quadrants, the 4 quadrants or 6 quadrants analysis, but it says blind procedure. Now histoscopy, the sonography and histoscopy both has helped us in not only diagnosing endometrial carcinoma, but really with the precision diagnosis it can be done. And therefore the place of the diagnostic histoscopy prior to the sonography must be there. So sonography and endometrial thickness pattern for that, that's a cutoff limit where you do it for that. And of course, there is a lot of changes in the cutoff limit with the whether the cutoff limit is 4 millimeter, 5 millimeter, whether the color Doppler shows evidence of that, whether the bleeding continues in spite of a conservative follow-up for that, that adds to that. But diagnostic hysteroscopy is really one step ahead of the fractional curettage or a blind DNC for that. And therefore, the diagnostic gadgets, these two, has helped us in dealing with the endometrial carcinoma in picking up really a unique case for that. So before going to that, I must say that endometrial carcinoma, there are two. You must first of all divide when before therapy, whether it's a type 1 or a type 2. Type 1 is a predominant variety, about 80 to 90% are type 1 variety, whereas a typical endometrioid carcinoma. These are endometrioid carcinoma, and these are all definitely related to the unopposed estrogen. So unopposed estrogen is the main cause giving rise to endometrial carcinoma. These are type 1 carcinoma. The more graver and more aggressive variety is a type 2. And these are all the non-endometrioid carcinoma. And these are all either could be serous or a clear cell or a carcinosarcoma or other varieties, abnormal varieties of that. So these, the problem of therapy, particularly the surgical options, are much more advanced and more aggressive in a case of type 2. Then the difference between type 1 and type 2. The course of the disease is well defined in type 1, but it is not defined in type 2 for that. The etiological factors is somewhat known in a type 1, but we do not know the type 2, what is there. The mode of transport and the transmission and the spread of the disease, we are really know about type 1, but we do not know what is the course of, or what the methodology, what the methods of the transmission, paths of transmission of this particular entity. And of course, it has been correlated with the molecular biological principles of dialysis to the genomic thing. I think there's a lot of research going on that genomic. But remember that type 1 needs a relatively less radical surgery than the type 2 varieties. Type 2 needs a more radical surgery, and the predominant the spread of the disease in a type 2 could be more in the, not only in the pelvic lymph nodes, but in the para-aortic and as well as the omentum for that. So therefore, when we come to the surgical aspects of type 2, more aggressive surgery and more radical surgery has to be there for that. So these basic principles of differentiation has to be there for that also. And apart from it, the grade of the disease, the gradation, the nuclear grading is important, whether it's a grade 1, grade 2 or grade 3. This is also a nuclear grade, gives rise to a prognostic variable, one of the important prognostic variable along with the lymphovascular spread and all that. Then one of the most determining factor is the spread, whether is within the uterus and the endometrium, not going to the myometrium, or if at all goes to the myometrium, what is the extent of involvement of the myometrium? Whether cutoff limit is 50%, 50% of the myometrium, within 50% of the myometrium, or more than 50% of the myometrium spread is there or not. This is very, very important. And as far as the prognosis, as far as the surgical options are concerned for that, and you have to know beforehand for that. The paradox is that it's very difficult to know beforehand till the gadgets was not there. Now, MRI has become an urgent pre-operatively to define, at least to predict, you can guide you that whether the extent of the disease to the myometrium or not. How much to the myometrium, this is important for that. Second important, the extent of the disease below to the cervix. This is also important because the cervical involvement is usually gives some a more radical procedure has to be adopted as compared to the endometrial. And in the cervix also, you must find out whether involvement of the endocervix, epithelium, or to the stroma. We are concerned that if it is involved to the stroma, then we are concerned that it is a cervical involvement is there, and the treatment will be more radical than simple endometrial carcinoma with the less radical procedure for that. So these are some of the cases which is very, very distinct now, understandable, and the concept is changing, and this is a very important thing. And therefore, there are prognostic variables which I'll point out. There are some prognostic variables which has been distinct, which has been really proved scientifically for that. Another significant advances is the sentinel node sampling and endometrial carcinoma. Because this is a case where if early stage of the endometrial carcinoma type 1, it's very easy. Simple hysterectomy is enough for that also without a pelvic lymphadenectomy. Now, when we are doing a pelvic lymphadenectomy, the morbidity is mainly amounting to more than if you do not eat. And as you go on more, like a para-aortic sampling, it's a skilled procedure, it's a difficult surgically also, as well as the Momentectomy, which are more. This is more important when we find a type 2. We have to devote for that. But a type 1 and early stage disease limited to the cavity or endometrium, or at best, myometrium is 50%, less than 50%, with an early grade of the disease. I think less surgical, I think simple, as compared to the benign method, you can do a simple hysterectomy, and more radical procedure is not at all necessary for that. And whether the pelvic lymphadenectomy, whether you do it or don't do it, universally we cannot say that all cases of endometrial carcinoma, you do a pelvic lymphadenectomy. The question comes, you can do over treatment for that or under treatment. I think that's, you must find out whether I'm going for over treatment compromising the morbidity or under treatment compromising the quality and the prognosis. This is important. And sentinel node mapping is an adjunct to that. We can define both in a cancer cervix as well as the cancer endometrium. When we are targeting the lymphadenectomy, sentinel node, the mapping gives a very good opportunity to say whether you go beyond that or not, so that less radical procedures and improved morbidity could be there for that also. And of course, role of MRI, I told that role of MRI is very, very important. CT doesn't reveal anything excepting the nodal status. CT can give an information, but the MRI, definitely we get a lot of information as far as the myometrials. Here I will point out one thing, is the man and machine both are important. MRI, as far as the machine is concerned, it can depict it, but the interpretation is very, very important. I have seen the interpretation of MRI, the man which knows the knowledge, I think that must be improved and must be a reliable radiologist to give a definite opinion on MRI. Otherwise, again, you do the surgery, and after that, you again, during the surgery also, there is a place to find out whether you go for the lymphadenectomy in the course of the disease. You just say that after doing a hysterectomy also, you can know that what is the extent of the disease. If you cut it microscopically, you can find out, or you can do a frozen section and send it the specimen, and then you can proceed whether decide for the lymphadenectomy. This is only in the case of type 1. But in a type 2 and in the more aggressive grades of the disease, nuclear grades, I think there is no compromise of doing a lymphadenectomy, even for para-aortic also for that. That's the message which I will give you. And the surgical options, again, radicality should be there for that. And the lymph node dissection in the pelvic lymph nodes, the first and level 1 and level 2 are the pelvic lymph nodes, external iliac and interiliac, and common iliac, including the presacral for that also. And level 3 are aortic, inframesenteric, and level 4 aortic, infrarenal. Aortic, para-aortic lymph nodes are difficult. Both left and right side has to be clear for that. One should know the risk of the para-aortic in relation to the ureter, in relation to the perforating vessels. This is important, perforating vessels for that. And the limit, what is the limit of that? So inframesenteric artery is the limit with the origin of the aorta, and below it, it's really advisable and safe for that. But perforating vessels, one must be very, very clear about it. The left renal vein has to be very clear about it, identification of that. It could do a open, you could do a laparoscopic procedure, but there is a place for para-aortic node in selected cases when now the gadgets are available to know the involvement for that. And when we know that the type 2, this is more aggressive necessary disease, and it is necessary to approach the para-aortic. Now, this is the FIGO staging. I did not say about stage 1, A, B, and tumor confined to the corpus uteri. A is no or less than half myometrial invasion. No invasion or less than half myometrial. An invasion equal to more than half of the myometrium is stage 1B. Stage 2, tumor invades the cervical stroma. Remember, the cervical endometrium, the epithelium is not stroma, but doesn't extend beyond the uterus. And stage 3, A, B, and C. A, local and regional spread of tumor. Tumor invades the serous of the corpus luteum under head neck size A. B, vaginal or parametrial involvement. C has been divided into two, whether C1 positive pelvic nodes or C2 positive para-aortic nodes for that. And of course, stage 4 is more advanced for that. And along with that staging, histopathologic grading has to be done grade 1, grade 2, and grade 3, because these are the grades of the disease which is related to the prognosis of the therapy for that. So the histology is very important. Endometrial adenocarcinoma, predominant cases 80 to 90% belongs to the endometrial type 1 variety, and type 2 more radical procedure options has to be given. And these are prognostic features of endometrial carcinoma. The race, the Hispanic, the black versus white. These are all racial differences where it is more. Of course, the FIGO stage, as far as the FIGO staging is concerned, more is the advanced the stage, more radical the procedure should be there. And this is very, very important to know about the depth of myometrial invasion, the tumor grade, the histologic subtype, the cervical involvement, adnexal involvement, and of course, the positive pelvic washings. Here, there is a controversy about the positive pelvic washings. No controversy in ovarian, but controversy in the corpus. And particularly here, I think the national NCCN has given a different opinion in comparison to the FIGO and WHO. The FIGO say that there is no real value of positive pelvic washings for that. But the NCC, the Comprehensive Care Cancer Network, this group has really proposed that there is some benefit of positive pelvic washings for that. And of course, the metastasis to the pelvic or para-aortic lymph nodes. More is the metastasis, particularly in grade 2, more is there. Lymphovascular space invasion is important. And at last, the genetic or genomic study has played a great role for that. And DNA aneuploidy is also one of the prognostic features for the endometrial carcinoma for that. The surgical options for endometrial carcinoma, therefore, hysterectomy, lymphadenectomy. In early cases, in type 1, simple hysterectomy without lymphadenectomy can do that for that. But lymphadenectomy, pelvic lymphadenectomy, and para-aortic lymphadenectomy, and the significance of the sentinel node sampling, this is important. And there is a place for frozen section for that. There are some authors who say that no, there is a difference. Frozen biopsy may not give an idea for that also, and don't do an advanced surgery for. But I feel that frozen section is definitely a place for that. And significance of the sentinel node surgery, then some special cases need attention for that. What do you do for surgery for morbidly obese patient? Now thing comes. In a very early stage, say for example, stage 1, there is a place for vaginal hysterectomy also. There is a place for vaginal hysterectomy in this particular case. And therefore, those cases, we can remove the ovary. The gland is not necessary for that. If you evaluate preoperatively, there is a place. Surgery for young patients, ovarian conservation. I think this is an important variety. In a case of type 1 is acceptable. There is no problem for that. But the controversy arises in type 2 varieties for that. And surgery for non-endometrial histology creates a lot of confusion. For the endometrial histology with early grade, the very simple and very clear-cut decision has to be taken. And more important is uterine sarcoma. When there is a sarcoma, the varieties, the gradation of the FIGO has given a different classification of the sarcoma rather than the carcinoma for that. And sarcoma, whether it's a leiomyosarcoma or adenosarcoma or carcinosarcoma, and the varieties of that gives rise to that. And the treatment modality, the prognosis is worst in a case of sarcoma, and the therapy, surgical options are listed in this particular case. And Lynch syndrome, hereditary Lynch syndrome, the combination of the colon, the breast, and the ovarian syndrome for that also identify. And this needs a genetic analysis. And therefore, we find that yes, Lynch syndrome is an entity by itself, is not. The more problem occurs with the undiagnosed endometrial carcinoma. It's undiagnosed. I think iatrogenic undiagnosed is a different entity. You fail to diagnose, you have not done a proper investigations, and then subject the patient for that. We have seen cases where simple, without a proper investigations, the hysterectomy has been done. And by sending the specimen for hysterectomy comes as an endometrial carcinoma. and or in the case of serous or in this case, what will you do? Again, a second sitting, either option is that. A second sitting, you have to operate for that, a review and do the lymphadenectomy and rest of the procedure, more radical procedure, depending on the histologic grade for that. Undiagnosed endometrial carcinoma. And this is very, very important. And some cases you miss it, we do not know. And then finally, when you get the sample, it comes, this is again an entity which has to be concerned for the gynecologist. Now, therefore, when we come to hysterectomy, the surgical options in endometrial carcinoma, the MIS, the extrafacial hysterectomy is the preferred choice. Here, there is no controversy about it. Unlike the carcinoma cervix, in endometrial carcinoma, there is no controversy that you will do, you will not do laparoscopy. Laparoscopy is accepted for that also. So laparoscopic hysterectomy or extrafacial hysterectomy with or without lymphadenectomy is the choice which is there. But there is a place for abdominal approach when there is a contraindication to laparoscopy, too large a uterus to be removed intact vaginally, extensive surgical history precluding laparoscopy, and evidence of advanced disease or the grades of the disease. Type 2, we must be cautious about this type 2 disease where you need a more extensive surgery for that also. So therefore, there is a place for laparoscopy, hysterectomy, radical hysterectomy in this particular case. Now, when we come to the lymphadenectomy, I have already briefed that surgical options, the risk versus benefit, extent of lymphadenectomy, what to do with or without the sentinel node biopsy. This is there. There are some guiding variables where you can do that for this. And then and there, after doing a hysterectomy, you just see and type up the local spread up to the involvement of the myometrium. And you can send it for frozen section also. This is another option for that. And of course, you can find out if it's a type 1, you can restrict it. Type 1 limited to less than 50% involvement. These are the cases. And grade, of course, you know it pre-operatively by doing a hysteroscopy and a biopsy, that early grade. No need of doing a lymphadenectomy. These are the cases when you screen it, you can do a vaginal hysterectomy also without that, like a benign case for that. So there are some guiding variables for that. Now, this is a case which, again, my oncologist friend Susil has given. There's the sentinel node biopsy. The ICG is the correct treatment for that, but is given with the methyl blue also can give some of the idea. ICG is accurate for that. And ICG in endoscopic now also with ICG compatible camera, you can see and diagnose the involvement of the lymph nodes for that. But at 3 and 9 o'clock position, about 3 or 5 cc of the methyl blue is injected. Normally ICG 2 to 3 cc in 3 and 9 is enough for that, and that is accepted. And then you see on the laparotomy, you can find either on laparotomy or by the laparoscopy also. You can find the clearly, even with the methyl blue also, you can find the nodal involvement here. So this is very, very an aid to that. And I feel that this is also a part which gives a lesson to the gynecological oncologist, that some satisfaction that yes, with this also with the open, we can see the involvement of the sentinel node for that. And therefore, this I presented that yes, only to show you and brief you that it's not the ICG alone. With the normal methyl blue also, you can inject it and find it out for that. So this is one of the cases where I can show that this is a case, how you can demonstrate that. Now, again, this is again a lap radical carcinoma endometrium, and one of my students, Dr. Manoranjan Mahapatra, I think is a very, very aggressive laparoscopic surgeon on that. And once upon a time, he was a student of mine, and now he has become a teacher of mine. You see the procedure of a lap radical in a case of carcinoma endometrium. There is no controversy about it, but again, be very, very gentle, and the appropriate instrument must be used for that. And there are various, earlier we are giving a lot of importance. This is a harmonic. Harmonic is a very good instrument for that, for dissection, as well as particularly for endoscopic procedure. In a radical, but still the newer innovations of the shear is very good, cheaper, and it is equally functions to the harmonic, because the vessel sealer, the sealing or hemostasis is much better for that. You start with one. There are various techniques in laparoscopic radical, the Galaxy technique by Silas, the Deepak has gone revolution. These are all standard procedure, and these are all, I really salute these particular innovative surgeons for that. And there are many, many surgeons who have come out. I see the young, dynamic and vibrant surgeons and doing how absolutely under vision for that. So here, basically the difference, identification of the different space. The two space is important, paravesical and pararectal, and then see if you're going to the proper space, I think the bleeding will be less for that. So that is important to identify that. The ureteric dissection and the uterine on the one side, the left side, you can find out. And here the uterine is there. You can dissect it just above the ureter. And ureter at the tunnel end of insertion, the dissection is being done at the level of the so-called tunnel, ureteric tunnel, so that it's cleared on one side for that. And this is why this space is important. The technology has helped us also, the electrosurgical principles as well as the harmonic or ultrasound technology, which has helped us for that. And be very, very meticulous and very, very defined, particularly at that level where is just 1 centimeter before the insertion. That's a very critical zone in terms of the bleeding because of the veins, which is very, very common there. And then, so this is very, very important to dissect it, identify that. Now we can find that the ureter is completely gone and adherent to the bladder. Now the posterior dissection course of the uterosacral, you just go it from one side to the another, and then you can find out the denalveolar space and enter into the posterior part and displace the rectum along with this fat, so that you know that fat belongs to the rectum and belongs to the bladder. You go a little above it and you don't find any bleeding for that. And the most important now, you find entering into the, you can clearly define the uterosacral and the parametrum. It's very clearly defined by the laparoscopy. You can very well demonstrate for that. And believe me, these are the fats which is important. The proper space, if you are not going to enter, that will cause a problem for that. And in laparoscopy, there is an advantage that you are going in hemoperitoneum and the gas will really open you and guide you towards the proper space of avascular space for that. This is very, very important to find out the uterosacral, where on the lateral aspect and radicality is being conserved for that. Depending on the lateral extension, as I've already told, how much you take it, whether halfway or full uterosacral at the level of the rectum, you just coagulate with that. And you can do it with the simple vessel selling system with the sear designed by our Indian instrument companies, and the PB and Alan, and these are the two companies which I always favor that, and I'm very happy with the dissection and the hemostasis of these sears in comparison to the harmonic. Because of the cost factor, this is important. So these are some of the space which I can say that yes, you go through that particular pararectal or a paravesical space and identify the structure. I think after ureteric dissection, the uterine ligation, and then you can clearly see that yes, enter with that space for that. Minute amount of bleeding is not a problem for that. You can just coagulate with that and finish it with that. So these are really a laparoscopy will be a very well satisfying the minimal invasive. This is why you see that the bladder is reflected with that from the cervix, and this is the part where the lateral bladder pillar which has been dissected, and unless we dissect it completely, we cannot go for a lateral extent of the excision, and that therefore this excision process, if you do it parametrum, good parametrum has to be taken. You have to dissect it all around, both anteriorly, the posteriorly, and the lateral part, and then enter the procedure and cut the vagina and take the proper length of the vagina, and then do the procedure, and it will be very easy to follow that and you can deliver the uterus. After that, you can deliver the uterus by vaginal route for that. Remember, the delivery of the uterus is again a factor to be considered. When the era of when morcellator was there, a very big uterus is there, it cannot be delivered. So morcellation, no morcellation in case of this malignancy. I think these are the cases where even manipulation of the uterus, even the uterine manipulator or the myoma screw has to be restricted for that. And because of that, you have to, this is a small uterus, it can be delivered through the vagina, and these are all lymph nodes. Then the procedure of lymphadenectomy over the external iliac. There is a chain of lymph nodes which can be just removed it in chain, and this is, you can find that the obturator vessels will find it at that level, and the whole chain in block you must deliver it, and with the harmonic or with the sear you can do the procedure very comfortably, bringing from the lower part, identify the internal circumflex vein crossing the external iliac artery, and that is the limit. You don't go much below that, and above is the common iliac mid-level, and you can clearly dissect it above the external iliac artery and vein. Both external iliac artery and vein are there. There are small twigs, and that is being tackled with the just one blip of the bipolar vessel sealer for that. But this is important. Don't pick up one particular node and then change it. The whole chain has to be found out for that. And now this is entering into the obturator fossa, and to find out the chain obturator node. And here is the limit, the lowest limit of the obturator node. And on dissection, you can find the limit is again an obturator nerve. And this obturator and internal iliac in one chain, you can do that, and you can do that. Now, individual variation is there about the lymph node number, lymph node characteristics. There is a variation of that, and of course, according to the involvement of that, the lymph node size. As in previous case, we have found a large lymph node which comes out to be positive for that. So all around, you can see the skeletonization of the vessel, which is being done by laparoscopy, and the chain completely can be delivered, completely can be dissected right up to the level of the common iliac, and common iliac right up to the level of the common iliac. And if you find the presacral also or parametrium area, rarely we find also, that can be delivered for that. Now this is the limit. You can identify the obturator nerve. I think the obturator nerve is the limit when you can find, and the obturator and the internal iliac can be very well dissected, and don't go below the obturator nerve. There is nothing, no node is there on the obturator, below the obturator nerve for that. So whole thing is skeletonized. You can clearly see the anatomy of the nerve, the vessels, the external iliac artery, the external iliac vein, and do the procedure. One of the tricky things is that the internal iliac vein. Internal iliac vein is a very, very short, and that creates a lot of problem. The length is very small, so don't enter into that. While entering into the obturator fossa and internal iliac, just below the internal iliac lymph nodes lies the internal iliac vein. So therefore, meticulous step has to be taken, knowing the anatomy of this internal iliac vein, just lying below the internal iliac node. And the other side, this is the other side, which is again going for that. The lateral extremity is the psoas. The lateral part is the psoas muscle, which is the limit of the psoas muscle. You can find it out for that. And of course, you can identify the nerves, and you can do a nerve sparing surgery in some cases for that. This is a typical sear which is there. It's not a typical sear, is much better than the harmonic, which you find very, very the cost effective. The country like India and place like Orissa, I think this, I'm very, very happy with this type of sear designed by our Indian company, instrument company for that. And you see that how beautifully the skeletonization is being done, and the whole of the chain is being just delivered it for that. Now the question comes whether these cases should be done with 2D or a 3D. I think 3D advantage is much better, and therefore we say that if at all the robotic has a place, because the 3D component is there in the robotic surgery. But when a 3D telescope is there, 3D camera is there with you, I think no chance. There is no better advantage of robotic and spending so much for that. It's a marketing gimmick for that also, I feel. And these are the cases where non-robotic with 3D, you can do a much better thing for that. And you find that the whole thing, here you can find that going to the deeper level and the parametrium for that. And there you must be very, very cautious about the intrailiac vein. The vein causes a real problem. It's a very, very small vein for that, but distinct node can be found out in that particular obturator fossa, which you can just find it out. Be very, very gentle. Hemostasis to be there for that also. Knowledge of the anatomy and the different space finding, the pelvic space entering. If these criteria is taken into account, I think you can do a good job and you can do a much better procedure than conventional laparotomy for that also. And laparoscopy has really a benefit for that. All studies shows that yes, although the laparoscopic radical has become contraindicated in carcinoma cervix because after the LHS trial, but for endometrial carcinoma, there is no controversy. And particularly these are the cases, there are some additional advantage because the patient profile are obese, diabetic, hypertensive. So because of the obesity and all that, there is a restriction of giving a anesthesia, starting from the anesthesia to the different post-op complications and procedure, where the endoscopic method is a great advantage for that also. Even with the regional anesthesia also, this procedure can be done. You can supplement it with the general, but with the depending on this particular risk cases, the anesthetic risk has to be balanced between the benefit, and therefore you can find that the whole thing is very, very skeletonized and absolutely clear. And now the anatomy, you can know that yes, we have done a good job at least removing everything for that. But at the same time, the indications of the pelvic lymphadenectomy has to be there. Where not to do it, I've already told. Where without an early stages and in type 1, I think there is a place for the only hysterectomy, type 1 hysterectomy, and that can be done even vaginally also. So these are the methods where laparoscopy has a real benefit over the conventional laparotomy for that. So this is one of the client which is left behind, which is not there in the higher level at the common iliac part for that. The upper chain of the extrailiac group, which is left behind, and therefore it has to be done for that. And whole chain, the meaning thereby that whole chain has to be done. And this is the obturator nerve, which is a guide. As we see on the other side also, this is again the same thing. We put it on the bag and remove it through the vagina and then send it for histopathological. The only thing is that in laparoscopy, now you have removed it, the vagina is already open. You put a gauge in between and you see that there is a gauge in between the, you place a gauge in the vagina for that the pneumoperitoneum to be sustained, and you can find clearly the anatomy on these two sides and absolutely dry, and you see the posteriorly the bladder, the ureter on the two sides and going entry into the bladder and the rectum and the vessels in the pelvis with the nerve, the typical obturator nerve, and this is the ureter, and you find the whole obturator foramen is empty and well dissected the end of the procedure. Now again, this is a case where there is a type 2 varieties and type 2 variety of carcinoma endometrium evaluated, diagnostic hysteroscopy, the grading is grade 2 or grade 3, and here we find that the operability is first and foremost is the operability part, abdominal radical, decided for abdominal radical for that. So normally this depends again, indication of the laparoscopy is again related to whether it's a type 2 or a type 1. Type 2 is not an absolute contraindication for the laparoscopy, but type 2, the benefits of abdominal conventional could be there for that. You can see the anatomy, and this is a case where the infundular pelvic, you just go as lateral as possible, as high as possible, and either you can do it with the suture or without suture. And this is what I was telling, that the ureter dissection, and ureter dissection just lift it and separate it from the, and opening the two space. I think creating the space is important, and this is the uterine artery at the origin. Then the anterior dissection comes, and this is a technique where we find that yes, there is no adhesions for that, and usually it doesn't. Only in a case of cancer cervix there could be adhesions, and the initial step you do go enter into this space and do the procedure for that. And then the ureter, you can see the ureter, just strip it off, and you need not skeletonize the ureter for that. And that is the end of the procedure of ureteric dissection. Then the uterine artery is very important. Then you go enter into the tunnel after the uterine. You can see the clear uterine artery, and the entry part is that is really a little difficult procedure, because the vein could be there for that. The roof, the tunnel, the endometrium is there for that, the tunnel of the ureteric tunnel. So these two spaces is important to identify, and then go for that. On the opposite side, you have again dissected the opposite side. Here, the transversely the uterine artery crosses the external iliac, and that point is important. So dissection in the course of the ureter up till the level of the uterine, and then the uterine, you can beautifully find out the uterine, and then go on the opposite side to tunnel. And now the tunnel is there, and you can completely free the tunnel for that, right up to the bladder. And this is the posterior dissection, which is there in the uterosacral, and the right cleavage, if you go it, and then you can find that yes, the two uterosacral and the cardinal ligament very well dissected right up to the level of the rectum, so that you can go halfway or close to the rectum, as lateral as possible to the rectum, depending on the stage of the disease. This is gone almost close to the rectum. We have gone it for that, and you just ligate it, or you can also apply the vessel sealer and do the procedure for that. So these are some of the same procedure, both conventional as well as the laparoscopy. I have defined one case laparoscopy, one case the laparotomy, depending on the grade of the disease and the stage of the disease and the type of the disease. You decide what to do, and of course your technical skill. If you're conversant with the laparoscopy, I think you do it a laparoscopy, and if you're conversant with the open, do it with the open. I think nothing, the results are all same for that. And the only thing is that the patient will get a benefit if you go for a minimal invasive surgery, and that is the thing for which we are interested, that if a laparoscopy is possible for that in a type 1 disease, particularly this is very important for that. And this is a case where you go for lateral extension to the cardinal ligament, and the cardinal ligament is there. Then you can find a sufficient length to the vagina, and just open it with the unipolar current, and you can find the extent of the disease here, that how the bulk. Can you see the side of the bulk? Here is a side where is abdomen, and therefore now you have closed it. And here again we go for this particular case, the running suture in the endometrium, in the vaginal vault for that, and complete it and drainage it, drain, you leave it for that. Now again, a case where we find that this is a case where again a carcinoma endometrium, where evaluation has to be done in open case, and these are the cases where really it merits attention. The same procedure, you go for the dissection, and this is the uterine artery at the origin. You can find it out and clamp it after the ureter has been dissected right up to the level of the uterine artery for that, and everything is done and clear for that. And therefore this dissection on the left and right side both, and lateral extent of the disease going for the Meckenrod and the parametrium. You see the extent of the lateral extent which has gone right up to the rectum. The plan is there, and then the vagina is open, and then vault is open, and you can close it with that. And then after that, the vaginal closure with that. Then we go for the lymph node lymphadenectomy, and this is mainly for the drainage in the central part and hemostasis on the edge of the vagina. This is an optimum procedure for the vagina. The quite good length of the vagina has been removed, and here we find that yes, that is the situation where we can go. This is a typical case where it's a stage 1 disease, whereas the previous case there was extension to the cervix, and therefore the endometrial carcinoma is there, and the cervix is also, so stromal involvement could be there, and the treatment would be same as per the carcinoma cervix, and that is the procedure in my previous case. You have seen it for that. So these are the two different cases. More advanced, the first case I've shown that is more advanced, then this is a case where it's there, and again this is the lymphadenectomy using the bipolar. This is the nerve which is there. Nerve sparing surgery can be adopted for that, and identifying the nerve and removing it and sparing it, and then so this is all the external iliac chain which has been removed on one side, and then it's a block, end block, you have to remove this, and that gives a very good opportunity of a prognosis that you are completely doing it rather than skip a palpating one lymph node as previously being done. I think this is a new concept of the gynec-oncologist to remove it and block so that the prognosis is much better for that. These are again how to retract the external iliac vein so that you enter into the obturator fossa, as we have shown in the last case also. This is a obturator nerve which is there. Identify that. Don't go below. Above the obturator nerve, whatever the nodes are there, you clear it right from the internal circumflex vein, and that is the limit which you design it and go and start it from there and upwards till the common iliac. You just do it. And this is a point where the obturator nerve is found out, so that the obturator gland as well as the intrailiac gland both can be tackled in this obturator fossa, and more proximally the intrailiac will be there, more distally the obturator will be there for that. So this is the whole chain of lymph nodes that has been dissected and removed, and little bleeding point can be tackled with the bipolar forces for that. And the ureter, the obturator nerve, and the external iliac and the external iliac artery and vein, both are visible on that. And then this is the opposite side which you are doing it. The other side, same procedure. We do it with the bipolar, with the proper anatomy. You can dissect first the external iliac artery and vein, right up to the common iliac you go it. And there's the uppermost part is the right is the common iliac chain. You can find it out for that. And then you go to the obturator fossa, just retracting the external iliac vein. Laterally, you can enter into it, and deeper, the main identifying factor is the obturator nerve. I think these are the, at the end of the procedure, the beautiful anatomy which has been shown. This is the uterine which has been ligated, and there is the external iliac artery, vein, the ureter entering into the bladder, and the obturator fossa completely cleaned, and the rectum has gone more posteriorly for that. So this is abdominal carcinoma, the abdominal radical for a carcinoma endometrium in a type 2 variety where pelvic lymphadenectomy has been adopted for that. And of course, we have done in this case, CT doesn't reveal anything on the parametrium, and care is to be taken to target whether the parametrium is involved or not, but intraoperative analysis will show that. And then because it's a stage 2, I think even if we do not find the parametrium involvement, the para-aortic and lymph, the momentectomy is being contemplated here. Here, the stage 2 and grade 3 varieties, the option is either you send it to the frozen section, or you can do the more radical procedure, presuming that in this particular variety, the chances of the nodal involvement of para-aortic is much more for that. And also momentum. Some people do a momental biopsy and assessment of the node, but I think depending now, it's very clear that in the type 2 varieties, non-endometrioid variety, I think there is a sufficient indication of this particular approach of more radical procedure, including the momentectomy and the momentectomy procedure is there, and para-aortic also should be involved. It's a difficult procedure, para-aortic, but skilled hands, we can do the procedure. The risks are much more. If you are very, very careful on the perforating veins, identifying the structure, the ureter, and the renal vein, I think you can do a good job for that. And be cautious about that particular thing for that. Now here is the case where we find that yes, it's a very rare case where we find a double ureter. Can you see that is a double ureter which is there on either side? The same procedure is there, but the double ureter. At times some congenital anomaly behaves the problem for that, and therefore the double ureter is there. Giri has found a really a typical case where the job is finished for them. Here again, we find the para-aortic lymph node dissection. After the clearance of this is the picture. We find the renal vein, we find it, and the crossing, and the common iliac, the aorta, and clearly the upper limit is the inferior mesenteric artery, and whole thing has been cleared both on the right and left side with special precaution to the perforating veins and the torrential bleeding for that. So this is open method, and this is the ureter of the right side, which is there, we can see. And these also, the proficient endoscopic surgeon can do the para-aortic dissection also. With that, routinely they can do it. But para-aortic in endometrial carcinoma is also indicated. I've told that in type 2 varieties, in advanced cases, and where we pick up the para-aortic by suspicion by the CT, I think these are the only indications where you can do that for that. So this is one of the para-aortic. And this is again a para-aortic after the completion of the procedure, the little oozing and in small injury to the veins has been repaired with that. And that is that gives the pleasure of removing that. This is a very good thing that yes, there is liable to injury for that. But at the end of the procedure, you can find that everything is good and it is clear. All the anatomy is very, very clear for that. And then this is an momentectomy, which I initially also have shown that. And this is a procedure of momentectomy, which is being adopted even in a case of the endometrial carcinoma in the non-endometrial variety for that. And be very careful about it. The cautery helps us, and the vessels is very, very important. The good hemostasis has to be done. And this is a unipolar, which cuts it and all that. At any point of time, just touch it at the bleeding point will be there. If you're going to the proper cleavage, just taking care of the vessels, smaller vessels, trigger vessels, I think you can do a good job in the momentectomy for that. So momentectomy is one of the procedure which can be needed, not routinely in a case of endometrial carcinoma, but routinely in a case of ovarian carcinoma, this is necessary. But there is a place of momentectomy and para-aortic lymphadenectomy in certain cases of endometrial carcinoma of grade 2 or type 2 varieties, and when the metastatic were demonstrated by CT, you can find it for that. Thank you, Sanjay. Thank you, Alad, for that, for giving me this opportunity again for this 26th episode. And I apologize for the little problem in between because of the digital break of the connection of that. But at last we can again join and have a good day for that. Thank you.
Thank you very much, sir. Thank you very much for a very knowledgeable and informative session. Thank you very much.
Thank you very much, sir. Thank you.
Please stop the recording.
Thank you very much, sir.
Thank you. Thank you.
Thank you, Dr. Navle.
Thank you, Nilesh.
Okay.
Thank you. Thanks, Aditya.
थैंक यू सर. महापात्र साहब, अलग साहब लॉगिन कर रहा है. अलग साहब लॉगिन कर रहा है. शायद से आपके साथ कुछ 1-2 मिनट बात करना चाहता है सर.
ठीक है.
वो डिस्कनेक्ट हो गया था.
Please stop the recording.
कंट्रोल रिकॉर्डिंग स्टॉप कीजिए.
सेटा किधर देखो. महेंद्र
recording stop नहीं हुआ है अभी तक.
Sanjay, is there any feedback questions?
Sir, there are no questions, sir, actually. But there are few questions regarding your efforts. They are admiring your efforts.
Thank you. Thank you. I am really grateful to my
Dr. Nilima Yadav from Lucknow, Subrata Das from Ambikapur, Shivani from Jammu,
Thank you.
Dr. Manoranjan Mahapatra from Tinsukia.
Oh, good.
Admin, you can stop the recording.
Record.